Well, ladies and gentlemen, and now we move on to our next segment, that is Partner Spotlight. So we have our first partner, a proud partner, Prodoc AI. Prodoc AI is an AI-powered patient engagement platform helping hospitals, thousands of hospitals, automate communication and streamline care journeys through voice AI, WhatsApp, SMS, IVR, and web chat in over 135 languages. Trusted by 100 plus healthcare providers and having impacted over 1 million patients. Prodoc AI is making healthcare communication more accessible, personalized, and measurable. And to tell us more about transforming patient care through conversational and agentic AI, we have with us our next speaker. Please put your hands together and join me in welcoming Mr. Raghuvamshi Thakur, a big round of applause, co-founder of Prodoc AI. He leads product strategy and innovation, focusing on conversational AI, agentic AI, and workflow automation to improve patient outcomes and simplify healthcare delivery. So once again, let's give it up for him. A very warm welcome to you, sir, and over to you.
Yeah, okay, I'm audible. Right. So, thank you, healthtech team, for the opportunity. My name is Raghu. I'm one of the co-founder of Prodoc AI. We've been around for 4 years. We work with over 100 hospitals, building patient engagement platforms and implementing this at scale. We have over 1 million patient engagement every month today on our platform. I would have talked about the product, but I thought it might be better to talk about the philosophy that we have been using and how we have been working towards our goals. This is a tweet from Naval Ravikant very recently. He actually said a couple of things. One was the age of the horizontal SaaS is primarily coming to an end. Right? That's primarily because the cost of building a software is coming drastically down on almost on a daily basis. Right? But he also mentioned another very interesting thing. Right? He mentioned that the amount of effort that a software would or a company would want to put right now would be in a horizontal SaaS and then try to deliver an end-to-end platform. Right? I agree on both aspects, right? Because we've been talking about horizontal SaaS, we've been talking about the vertical SaaS for over 4 years, and a lot of people have questioned our strategy in terms of how we have been going about. What is also interesting is that we think that the AI has not changed the way we look at the software or we develop the software. AI has practically fundamentally changed the way we use the software, right? And that brings me to one of the first. I'll talk about three aspects. The first is the evolving first principle, right? Till, and I just want to break it down in terms of the software history of software, right? At around 90s, we saw the web. At around 2006, we saw the mobile coming in. And each of this had fundamentally changed the way we would build or we would even look at the software. Right? With AI coming in, there is again a very fundamental change in terms of the software lifecycle itself. Right? And that's primarily the consumer. Right? Most of the software that were built till before AI came along, the primary consumer of that software was a human. This first principle has changed, right? And we all have to understand the gravity of this statement, because if your first principle changes, which means you will have to not build a, let's say, wrapper around what you already have, but you will have to practically go and change the basis of where the software was built. That is pretty much what we need to do today, because the primary consumer of every ecosystem now would be an AI agent. It won't be a human. And human is a principal who's actually auditing, who's actually advising or suggesting or taking an action or triggering an action. But the execution of the action itself will no more be by an human. And this we're seeing to happen more and more, right? much easier to do it in a engagement space. We're trying to do it pretty much in every aspects of the way a healthcare is managed. And if you really look at the platform, the way we are envisaging the entire healthcare as a platform right now, would that there will be for every role there would be an agent, which means if I am a doctor and I wake up in the morning, rather than trying to call my secretary or somebody trying to call me, I would probably just go on a platform and just say, can we tell me the schedule today? Right? From the appointments to the number of visits, the patients who are already in the OT and what has happened, the progress, etc., can actually be informed to me without me having to do anything, pretty much nothing. Right? Similarly, if you look at from a simple nurse point of view, the biggest challenge for a nurse to start her work is to take the handover of where the last person left the work from. Right? Most of these handovers, most of this information exchange can now be done by agents to agent. You don't need a human in loop, which means as a human, I can come and get started and pretty much get on top of what we are trying to do almost on get go. The second aspect that I wanted to talk about was the moat, right? And again, a lot of startups we see in the house, and we all talk about moat. Right? We always keep referring to what is the moat for a software, right? Or what is the moat left now with an tech, right? At some point of time, development was in moat. Definitely, we all know that no software stack, no development is moat anymore, right? Pretty much everything and anything can be built in a shortest amount of time, right? You can start from zero and build everything that you would want to in 3 months' time, and you pretty much be there, right? At some point of time, when we were going through this whole AI cycle and we were working with a lot of industry stakeholders, we were told the model is the moat, right? Whether it is small language model, whether it's large language model. If we have known anything from what happened in Fable and Kimi being released in a week's time, and if model is not a moat for Claude, I don't think model is a moat for any of us. Right? We need to understand that part. So if model is not the moat, what is the moat for an ecosystem, right? And we strongly believe that the moat is primarily in the memory, right? Why? If you have an agent pretty much doing everything for you, the only way that agent can actually effectively do anything would primarily be in terms of how you're managing that memory for that agent, right? Which means um, an agent needs to understand who the person is. So whom am I working for? Um, how does the role operate? So what is the scope, right? Where were the last episodes? Where were the person there? Where were the patient in the journey? And how? What can we do next, right? And what is the information that is being exchanged? So what we are doing right now is we're building memory as the moat, because at the end of the day, your memory of a patient is what even a doctor is using to decide what kind of treatment that should be given to, right? That's why we always go back and try to see history. We try to go back and see in terms of what were the interventions done to actually determine what the next step is. That's pretty much where we should be focusing on. So instead of focusing on an episodic data, we are moving to a longitudinal memory, which means the memory keeps updating, keep revising. You also need to identify what should stick, what should not stick, what you need to remember, what you don't need to remember. 70-80% of OPDs that happen today need not be remembered because they pretty much have no impact on your next episode. Right? But there are ones that needs to be remembered, and how do you identify those and how do you bake that into your memory? That's pretty much where the engineering lies today. Right? I also want to talk about the third part, and again, wanted to talk also because all the health tech in the house. I also want to talk about the monetization part. Right? We very strongly feel that, and again, I think there was a question with respect to preventive care. There's been questions in terms of post-discharge expenses that a patient incurs, right? and this is pretty much in the outside the ambit of a hospital. What we think is basically, if you are a healthcare provider today, you need to be focused on the entire journey of the patient rather than focusing on a certain aspect. And yes, this was difficult when this was seen as an administrative overhead, but I can tell you that operation is the new growth function, which means the more the ecosystem evolves, the better will be the services that you can offer to the patients, the more cohesiveness and the more continuity of that care that you can build. And this will be pretty much done with no expense to the human capital. So the next decade belongs to the hospital that orchestrates journey. So we have passed the HIS and the EMR phase. Um, I personally believe we didn't do very well with the EMR phase. I think there is still a long way to go. I think with the scribing and a lot of solutions getting baked in, I think over time we would probably bridge that gap that we have built in terms of lacking a lot of OPD data, which is a direct consequence to everything that is happening in the IPD. Right? That is coming in. I think patient engagement and OPD intelligence is currently in the phase that we are. We're working with multiple hospitals. I think this is also the first time in the history of IT that solutions are now pretty much adopting to the way a clinical physician would like to work, rather than a physician would probably try to change his ways to um, adopt to the software. Right? We have heard stories about how doctors are were unwilling to let go of the eye contact that they had with the patient only because they had to type something in the EMR, and that's something that they were not willing to. Right? With the scribing and pretty much solution being now deployed at scale and with almost an accuracy of 97, 98%, I think we can pretty much ensure that that gap is taken care of. And this is only going to get better from here. Right? I just quickly wanted to talk about in terms of where Prodoc comes in. Again, like I said, the data intelligence is basically where we build our moat. That's our bottom layer. That's the place where everything starts. And this is also where the ecosystem integrates with everything that you have. We're not talking about a rip and replace kind of a solution. We're talking about a solution that can integrate with your entire ecosystem and build ground up. We have a very strong DPDP compliance ecosystem. And this is another something that we would like everybody to understand. With more and more agents, with more and more AI coming in, a compliance layer that is dependent on human is not going to work. There is no possible way that a human will be able to keep up with compliances that are actually triggered due to agentic workflows, which means you would need a agent first compliance layer to start off with, and that would pretty much be able to take care of all the data security that we've been talking about. And this becomes a very fundamental aspect of the entire solution. We pretty much right now cover the entire journey of the patient, from acquisition to retention. We have modules which are actually focused on different workflows, but we make sure that one thread that ties everything together is the data. Right? That's all from my side. Again, my name is Raghu. I'm happy to take questions. Thank you for your time.
Well, any questions? I think we can take a one or two. I know that we are running a bit of out of time. We'll take a question or two. Let's make it a little quick, sir. Thank you.
Hi Raghu, I'm Abhay from Harris Computers.
Hi.
So we operate good number of companies globally in healthcare. My quick question would be, can you slightly elaborate on one or two mission critical use cases that you helped with one of the hospitals, which can help us understand slightly more better about your offerings?
Right. Um, so let me talk about one of the use cases that we are actually mm, right now very widely deploying across multiple hospitals. That is primarily into the scribing solution that we have. So what we understood was that when we actually wanted to build agents, most of the Indian healthcare ecosystem actually lacked data, right? And when I say lack data, I don't mean from a documentation per se. What I mean is documentation in a way that it can be consumed by agents, right? Um, and good example is lot of EMR data is actually handwritten scanned data. It's pretty much not useful for any of the agentic workflows. So that is where we come in. What we have been able to do is we are able to build this ecosystem for clinicians where with a minimal intervention, they can actually have the entire documentation for their OPD visits captured. It also, while we could stop there, what we've actually primarily focused on is taking that data downstream, right? If there is some recommendations which are done as part of that OPD consultation, how does that trickle down to either operations team or how does that trickle down back to patient itself, right? So that's primarily where we are primarily building agents which can actually work with both patients as well as hospital administration to streamline that aspect, right? Simple things. Some and this is something that happened to me, right? I taken my mom for a post-surgery consultation. The last consultation, we were expected to get an X-ray done. Right when we see the doctor, we were actually sent back saying, "Oh, you had to get an X-ray done, and you didn't do that, right?" An agent, if we had a Prodoc like ecosystem there, right when we walked into that hospital, we would probably be told that we need to get that X-ray done right before even getting to the hospital, right to the doctor. Things like this, which actually costed 4.5 hours of an OPD time, not fun for anybody, including the doctor, right? Pretty much could have been done in much better way. This is one of the use cases, right? Another very interesting use case is pre-surgery prep and pre-surgery or yeah, pre-surgery engagement. So one of the very interesting use case that we actually heard from one of the hospitals in Apollo Spectra chain is that a lot of times patients are they've been scheduled for a surgery and there are set of instructions and set of things that they have to follow. A lot of these times these set of instructions are explained to the caretaker or whoever is accompanying the patient, and a lot of times there are a lot of discrepancy in terms of understanding of that information and actually enforcing that. Simple things, patient should not be taking water in 12 hours before the surgery. Very simple instruction to follow, right? A lot of time gets missed, delayed surgery, movement in entire the OT rooms, etc., happen just because simple stuff, right? We've been able to actually build and enable agents for specific surgery procedures and actually work with the patient almost 36, 48 hours before the surgery happened, right? So that patient could actually ask questions, work with the agent, do the clarification, and actually then enable that entire surgery procedure goes well, right? There is a couple of use cases in terms of where we are coming from, right? I hope that answers.
Hello, hi Raghu. My
Hi.
name is Ram. I'm from Pickle Health.
Yeah.
I think the bottom layer which you mentioned, which is around the compliance, and I think that was an interesting point. Now that the ABA and the ABDM, and then the various other DPDP Act and also. So what's your take on that? And I think it's all in very early stages at this point of time. How are you addressing? What are the checks and balances, guardrails do you have in terms of addressing the compliance area?
Again, thank you for the question, right? Very interesting aspect, right? At this point of time, DP is not um, it's not some policy in the air. It is coming. It's very concrete. Of course, there are gaps and a lot of things that we keep discussing as part of product. But I think there is a lot of clarity, and that May 2027 deadline seems like a very real line to work with, right? From what I was talking about, right? What we have done, especially in our product, is that we have actually defined contracts. These are the contracts that are assigned to agents, which actually does not just define the scope, that also defines in terms of how the compliances should be managed, the actions that should be taken even before some action can be taken. There is another thumb of rule that we follow for all agents, is that the agents don't perform any action which are non-reversible, right? For example, just to give an example, prescription is a non-reversible action, right? You take the prescription, you give it to a patient, patient walks out. That's it, right? It's done, right? There is no way to now go back and bring that out from the patient's hand. So these are the places where we don't expect agents to come in, or in terms of any suggestions that we can actually go to. So basically what the agents do is agents follow these contracts, non-reversible actions. Every time they want something to perform, every time there is an action that to be done towards the patient, it always gets flagged off back to a clinical expert or somebody who is responsible for that, and affirmations are taken and registered, right? I think there was something that was also mentioned before, that auditability has a very strong value, especially with AI agents coming in. You should be able to go and audit. You should be able to identify what action was taken, by whom it was taken. One of the other challenges in a CRUD-like system, like traditional HIS, HMS systems, is also that the usernames are exchanged across users, which means while you can audit who did it, there is no guarantee that that's the person who actually performed that action, right? With agents, that auditability gets pretty much written on uh, with stone, and then this is not something that can be modified. And because every agent is associated with a user, you also know that the actions will be performed by specific users, right? So that's something that I think is very interesting. Again, DPDP is an evolving space. I'm sure a lot of marketing companies are rethinking their strategy, because pretty much breaks everything that they've been doing till date. But yeah, we're looking forward to it. We actually have a very detailed understanding of DPDP. We've been talking to multiple hospitals, trying to see how this would evolve. Right? So thank you for the question. Yeah. Thank you.
Thank you, sir. Thank you so much for all the insights and the inputs that you have provided on the topic. Well, ladies and gentlemen, before we proceed, let me tell you, considering the timeline for today's event, request all our speakers to kindly make sure that you conclude your presentation within the allocated time. So kindly make sure that we're not delayed. Thank you. Right, so before we proceed, we'll hand over the gift to Raghu. I request Dr. Uma Nambiar to kindly join us on stage to do the honor. A big round of applause as we welcome both of them on the stage. So I request Raghu sir to kindly join us on stage. Thank you. Thank you so much once again from the bottom of the heart on behalf of the entire family of All Health into Tech Summit 2026. Thank you so much, Raghuvamshi Thakur. One more time, let's give it up for him, everybody. Thank you, sir. Thank you so much. Thank you, madam, for joining us on the stage to do the honor.